Welcome to the deep dive. We unpack source materials to find those really key insights.
That's the goal.
And today we're looking at a pretty compelling case study, actually. It gets right into those tough decisions, When you have a seriously ill patient, but also significant risks involved with treatment.
Yeah, and it forces the doctors to look way beyond the standard stuff.
We've been digging into sources all about this risk, medical innovation, and how crucial teamwork, collaboration really is.
Right. And our mission here for this deep dive is to pull out maybe the surprising facts, the key takeaways about what happens when the usual options, well, they're just too dangerous for the actual person sitting in front of you.
So the scene is set, the standard approach, not safe, and everyone has to kind of rethink everything for this one patient.
Exactly. Let's dive into the case itself from the sources. We're talking about an 85-year-old person diagnosed with pancreatic head cancer.
Okay, pancreatic cancer, always challenging. Standard approaches are definitely considered there.
Absolutely. But the sources really pointed to the patient's overall situation as the main hurdle, not just the cancer diagnosis itself.
What do you mean? What was it about their profile?
Well, they had quite a few significant pre-existing health conditions. And this is key. They were assessed as clinically frail.
Frail. Okay, we hear that term. But what did the sources say it meant in this context? Sounds like more than just being 85.
Oh, definitely more than just age. The sources were clear. Frailty isn't about the number on your birth certificate. It's about reduced physiological reserve.
Physiological reserve.
Yeah, think of it like the body's battery, its ability to cope with big stressors like major medical treatment. It's diminished.
Ah, okay.
So even though this patient was still living independently day to day, the assessment basically said that the massive physiological stress from standard treatments, it could cause a really rapid, irreversible decline.
That assessment sounds critical then.
Incredibly important. It framed everything.
Okay, so high-risk patient, assessed as frail, serious cancer. What was the core dilemma when they look at the standard options?
Well, given that profile, the standard stuff reviewed by the surgeons, the medical oncology teams, they just decided it was too risky. Plain and simple.
Too risky how? Let's break that down. Surgery first.
Right. Surgery for this cancer is, it's huge. A massive operation. The sources called it a marathon surgery.
Wow.
Yeah, massive physiological toll. The recovery is famously long, really arduous. And for someone with limited reserve, the chance of serious complications, maybe even not surviving the surgery or recovery, it was just deemed too high.
So the risks just outweighed the potential benefits?
In this specific case, yes, that was the conclusion.
Okay. What about chemo? Systemic treatment?
Medical oncology looked hard at that too, of course.
Yeah.
But similar conclusion, really. The potential for severe toxicity, just overwhelming fatigue, side effects that could really tank their quality of life was very real. And those side effects could easily just wipe out any potential benefit from the chemo itself.
Making things worse, potentially, not better.
Exactly. The sources use this great phrase. The patient was caught in a therapeutic vice. Treatments meant to help could actually cause significant harm.
Wow. That's a tough spot, a therapeutic vice. So standard paths blocked. What happens then? It wasn't just give up, right?
No, not at all. Far from it.
Yeah.
The sources show this wasn't a dead end. It was a problem to solve. And the key, collaboration.
Ah, the team approach.
Yes, and specifically the multidisciplinary tumor board. That was the crucial space where this happened. Everyone got together.
And the focus shifted, you said. The question changed.
Precisely. It wasn't, can we technically do the standard thing despite the dangers? It became, okay, what is the absolute best thing we can do for this person?
Taking everything into account.
Yeah. Respecting the cancer, yes, but also their overall condition, their frailty, and critically, their goals for life.
Who was around that table? The sources mentioned the key players.
And see, you had the surgeons, medical oncologists, radiation oncology specialists, and the palliative care team.
And you mentioned palliative care. The sources flagged their early involvement as really important. Why?
Yeah, that's a great point to emphasize. Palliative care isn't just about end of life, which is a common misconception.
Right.
From day one, their job was managing symptoms, yes, but also making absolutely sure the patient's own goals and values, like what does quality of life mean to them? Staying independent, things like that were central to every single discussion.
So they kept the focus on the person, not just the disease.
Exactly, grounding the whole conversation.
Okay, so this collaborative discussion happens, and an innovative idea emerges. What was it?
This is where radiation oncology stepped up with something called Stereotactic Body Radiation Therapy.
SBRT.
Okay, break that down.
Well, the sources describe it as a kind of non-invasive radiosurgery. Super precise. It uses really advanced imaging, like GPS-like tracking, they said.
GPS for radiation.
Sort of. To deliver incredibly high, very potent and ablative doses of radiation right onto the tumor. And the precision is amazing, like sub-millimeter precision. Sub-millimeter. That sounds incredibly focused. How does the treatment course compare to, say, traditional radiation?
Huge difference. Traditional radiation for something like this might be, 28 treatments, 5.5 weeks, going in every day?
Yeah, that's a long haul.
With SBRT, the sources said it was just 5 sessions, over about a week and a half.
Whoa. 5 versus almost 30. That alone sounds like a massive plus, especially for an 85-year-old and their family making all those trips.
Definitely. The logistical ease is a big factor. Fewer trips, less disruption. But the clinical advantages, the sources explain, are really profound.
How so?
Because that beam is so incredibly focused, the analogy used was less like a floodlight, more like a laser beam.
Okay, I get that.
It means it spares the surrounding healthy tissues much, much better. Things like the stomach, the intestines, which are really sensitive.
Leading to fewer side effects.
Dramatically fewer side effects. And importantly, the dose is so high, it's given with ablative intent.
Ablative intent, meaning?
Meaning the goal isn't just to shrink it a bit, it's to completely destroy the tumor cells. It offers a chance at long-term control, maybe even cure, that previously you really only thought possible with that big surgery.
So, a non-invasive way to potentially achieve a surgical-like outcome, but without the massive risks of surgery for this patient.
That's the essence of it.
How did the patient and the family react when this was proposed?
According to the sources, it was explained pretty clearly, like using focused energy to do what a surgeon does with a knife. They understood it was powerful, but short and crucially lower risk for them compared to the other options.
Which must have sounded like?
Like hope, yeah. Where before they saw these really difficult high-risk choices, now there was this other path. They were immediately on board.
And the outcome? Did it work? What did the sources say happened?
It was described as a resounding success.
Wow.
Yeah. The patient tolerated the 5 treatments really well, minimal side effects, easily managed, and the follow-up scans showed a fantastic response. Significant tumor shrinkage.
That's great clinical news, but what about the patient's actual life? Did it achieve those quality of life goals?
That's the most important part, isn't it? And yes, the sources emphasized they were able to maintain their independence, keep doing their hobbies, just live well.
Without that huge recovery burden.
Exactly. No long, painful surgical recovery, no debilitating chemotoxicity. They got a really effective treatment without the devastating side effects that everyone worried about, with the standard approaches for someone assessed as frail.
This case really feels like it pushes back hard against some common assumptions, doesn't it? Especially about treating older patients.
It absolutely does.
Yeah.
The sources frame it as a powerful rejection of what's sometimes called therapeutic nihilism.
Therapeutic nihilism.
Yeah, that kind of mindset that, oh, they're too old or they're too frail. For any meaningful treatment, especially treatment aiming for a cure or long-term control.
This shows that's not necessarily true.
Right. It shows the answer isn't always less treatment for high-risk patients. Sometimes it's smarter treatment, more targeted treatment.
And it highlights that with the right tech, like SBRT, and maybe even more critically, the right team working together,
Thinking outside the standard boxes.
you can offer highly effective, even curative intent therapy to people who maybe just 10 years ago might have only been offered supportive care.
Yeah, just managing symptoms without really tackling the cancer itself, it really opens up possibilities.
It raises an interesting point the sources touched on too about how we even structure those first consultations for patients like this, older, higher risk.
What's that?
Well, instead of the default being just, okay, see the surgeon, see the medical oncologist, maybe radiation oncology should be involved right from the get-go in that initial workup.
Bring them in earlier.
Yeah. Treat it as another potential pillar of definitive treatment from the start, not just an afterthought if the others don't work out.
That makes a lot of sense. It could open up options much sooner for the right patients.
It really paints a picture of the future, doesn't it? More collaborative, much more personalized, using these amazing technologies.
And really driven by a team focused on the individual, not just the protocol. We're probably just scratching the surface of what's possible.
Makes you wonder, yeah, how many other situations could benefit from that kind of thinking right from the beginning.
Exactly.
So I think that's a really powerful core insight from this deep dive into the sources. This case just shows beautifully how, combining that collaborative expertise, truly listening to the patient's goals, and using innovative tech like SBRT, it can create real powerful options even when the standard roads look blocked.
It's about refusing to accept perceived limitations and finding a better way for that individual.
Absolutely. So here's a thought to leave you with, building on what the sources suggest. If bringing radiation oncology in earlier for high-risk patients opens up this whole new pillar of definitive treatment, what other assumptions, what other standard workflows in complex care might we need to rethink?
Where else could a different approach unlock smarter, more personalized options?
Exactly. Something to ponder.
Definitely food for thought.
Thank you for joining us for this deep dive.